My pleasure and honor to present one of the eminent nephrologists in the world, Professor Mohamed Sobh. He's a professor of nephrology, Mansoura University. He's one of the eminent team in Mansoura Renal Transplant Center. Professor Sobh is an emeritus professor of nephrology and renal transplantation, and he's one of the pioneers in the field of research in nephrology, in stem cells, in all kinds of renal diseases. And he received the Nile trophy 2 years ago, I think. Yes, and it's an honor to present you, Professor Sobh.
شكرا جدا دكتور مجدي على هذه المقدمة التي قد أستحقها. هنا يعني من مش هشوف كده ما تعدش دلوقتي من هنا من هنا كده يعني. Okay. First, I'd like to thank my friends in the organizing committee for inviting me to give this talk in this high prestige annual meeting. First, I think we think that nanotechnology, autophagy, gut microbiota, all these are tools which will change medicine in the future. I think this change has been started. Also, today I'm going to talk about one of the tools which I think it will change dramatically medicine in the future. I'm going to present some experimental data about manipulating these Tregs in kidney field and transplantation, but as well the last slide will show starting a human trial using manipulation of Treg as potential therapeutic potential in nephrology and kidney transplantation. First, we know that the regulatory T cell, formerly known as suppressor T cells, are a subpopulation of T cells that modulate the immune system, maintain tolerance to self-antigen, and prevent autoimmune diseases. These Treg cells are immune suppressive and generally suppress or down-regulate induction and proliferation of effector T cells. Treg cells express the biomarker CD4, CD25, and FOXP3, and are thought to be derived from the same lineage as naive CD4 cell. Recent research has found that the cytokine transform TGF-beta is essential for Treg cell to differentiate from naive CD4 cell and is important in maintaining Treg cell homeostasis. What is this FOXP3 and Treg cell? The transcription factor FOXP3 is critically important for development and function of Treg. FOXP3 not only can keep the cell on right developmental track down toward a suppressive phenotype, but also seems to be a prerequisite for stabilizing the Treg lineage. Furthermore, loss of this FOXP3 expression over time impairs the suppressive activity of Treg. Treg critically depend also on interleukin-2 for survival and function, and the loss of functional FOXP3 and interleukin-T signaling result in Treg dysfunction and lethal early onset inflammatory disease. What about the different T cell population? CD4 positive FOXP3 CD high CD25 regulatory T cells have been called natural occurring regulatory T cell. Okay? To distinguish them from suppressor T cell population that are generated in vitro, as I'm going to show now. Additional regulatory T cell population are there. There are many, as you see here. The contribution of this population to self-tolerance and immune homeostasis is well defined. So we need a lot of work to identify these different types of Tregs. But FOXP3 can be used as a good marker for mouse CD4, CD20 T cell, although recent studies have also shown evidence that FOXP3 expression also can be on CD4 positive, CD20 negative T cell. So we need a lot of time to more in-depth understand this FOXP3 and Treg cells. Another cells which we call tissue Treg. It is becoming increasingly appreciated that Treg accumulate in various non-lymphoid tissue, not in blood and lymphoid tissue, are important part of immune system, local immune system. Tissue Treg have a unique phenotype, different T cell receptor repertoire, distinct function. Identification of non-lymphoid tissue, FOXP3 Treg, has fueled the notion that human immune system possess a second function other than suppressing effector T cells and autoimmunity and these things, maintaining organismal homeostasis. How? For example, this newfound function including help hair follicle regeneration, preserve intestinal homeostasis, and more importantly, participating in tissue repair. So not only immunity. What is induced regulatory T cells? Induced cell developed from mature CD4. The other one, natural, was naive, from naive CD4. Conventional cells outside the thymus. The other was inside the thymus. A defining distinction between natural regulatory T cell and induced T cell. Induced regulatory Treg cell are suppressive also and involved in tolerance and immunity as well. These cells include also Treg17. Acute depletion of induced T cell pool in mouse model has resulted in inflammation and weight loss, so it is as important as natural T cell. Treg formed by differentiation of naive cells, CD4 cells, outside the thymus, not inside, in the periphery, such as in tissue culture. It's called adoptive T cell. So we have many types of cells, as I showed now. Is there a relation between T cell and different diseases? Yes, big relation. While immune suppressive function of regulatory T cell prevent the development of autoimmune disease, so it is needed, it is also desirable during immune response to infectious microorganisms. Current hypothesis suggests that upon encountering with meeting an infectious organism, the activity of regulatory T cells should go down to allow the immune effector cells to destruct the invading organism. Experimental evidence from mouse models suggests that some pathogens may have evolved to manipulate regulatory Treg cell to immune suppress the host and so potentiate their own survival. So the organism damage the Treg, so it can give a chance for it to invade the body, destroy the body. For example, regulatory cell activity has been reported to increase in several infections such as HIV infection, to immune suppress the host. And also in TB, it had been reported to flourish Treg. Also some parasite infection, including leishmania and malaria. So this is the role of infection, relation of Treg and infection, and different organisms trying to play with it to invade the body. CD regulatory T cells are often associated with solid organ tumor. For example, in both human and murine model, increased number of regulatory cells in breast, colorectal, and ovarian cancer is associated with poor prognosis. Another point with pregnancy, with normal pregnancy, there is a flourishing in Treg, so that to induce what we call the maternal immune tolerance of the baby. And disruption of this activity of Treg will cause what we know toxemia of pregnancy. Now I will go to the kidney. regarding regulatory T cell and acute kidney injury, for example, this is a very interesting review article which talk about result of animal model have shown a causal relationship between leukocyte activation and the infiltration and kidney injury. Blocking the activation or tracking of pro-inflammatory leukocyte into the kidney preserved renal function and histologic integrity. In the same line, if we play with the Treg, intrinsic T cell, this will protect kidney function. This could be considered as a novel therapeutic approach and or target for pharmacological manipulation to ameliorate acute kidney injury. So this was a good article. And this slide is a immunofluorescent staining, double stain for CD4 and FOXP3 in a model of ischemia reperfusion injury in mouse. It shows infiltration of the interstitium by this Treg. The more Treg, the less kidney injury will occur. And this slide shows the different mechanisms by which the Treg can downregulate the inflammation and prevent kidney injury, either through direct action, cell-to-cell contact, or through humoral mechanisms. Now, this is a very recent article in which they describe using the endogenous Treg cells in acute kidney injury and as an abstract, since inflammation contribute to the pathogenesis of acute kidney injury, study on T regulatory cells which suppress inflammation are important. He gives example how Treg can affect acute kidney injury. It can protect from injury, giving the anti-inflammatory action of Treg and the critical role of inflammation in inducing acute kidney injury. The authors hypothesize that intrinsic Treg represent a vital component of the natural protective response to kidney injury. When an animal develops a recovery or no injury occur, it is the action of Treg which causes this. Two models of Treg deficiency mice subjected to ischemia reperfusion injury were used to investigate this hypothesis. In both models, Treg depletion, there are some drugs which can deplete T cells, enhanced renal inflammation and acute kidney necrosis and loss of function. This enhancement of renal injury was reversed when they injected distally or in vitro expanded Treg. In another mouse model that was induced by cisplatin, so this is a toxic model. The previous one was ischemic model. Treg depletion by this agent before cisplatin exposure also resulted in worse renal function and tissue injury compared to control. Again, another model, interestingly, a cecal ligation and puncture model. This is a sepsis model. Okay, sepsis model of acute kidney injury. Treg depletion with BC61 protected mice from renal dysfunction and improved survival. This is this is in contrary to the other. So, they concluded that intrinsic Treg protected from aseptic, ischemic, and nephrotoxic acute kidney injury, but on the reverse, it protects against septic acute kidney injury. Another model of ischemia and protection from ischemia is what called ischemic preconditioning. This is a powerful intervention to protect the kidney from reperfusion injury, in which, for example, if you are doing an experimental ischemic ATN, before occluding the renal artery by clamp for, let us say, 60 minutes, before this you do some occlusion for few minutes and you repeat it. This few minutes of ischemia is a preconditioning. It protects from the longer term ischemic insult. We call this ischemic preconditioning. A number of mechanisms contributing to preconditioning have been described, including change in renal nitrogen activated protein. But here there is evidence that Treg contribute to the preconditioning. Treatment of preconditioned mice with BC25, which deplete Treg before the second long ischemia, second more severe ischemia, partial or completely negated the protective effect of ischemia preconditioning. But interestingly, Shaw et al. Went on to show that adoptive transfer of isolated Treg to preconditioning Treg depleted mice restored the protection. Again, this signify or proof that Treg is important in preconditioning. Promoting recovery is another model which say not only it prevents but it can protect against. Taken together, these studies suggest that intrinsic Treg traffic to the injured kidney to promote repair from ischemic injury. Okay, another way. Targeting intrinsic Treg is expensive, tedious, difficult, so we have to find a way by which we manipulate the endogenous T cells by drugs. And this table shows a lot of medications, an example of these medication and how they interfere with Treg. They either increase Treg activity, increase Treg number, or Treg trafficking to the kidney. Many of these agents have been used to prove this statement. Kemet al reported that B venom, for example, increased Treg number in the spleen, enhanced Treg trafficking to the kidney after cisplatin administration, and protected against cisplatin-induced kidney injury in mice. Importantly, B venom had no adverse effect on the anti-tumor activity of cisplatin in this model. So this deserves trial in human. And this is the paper of P venom, and this is the abstract. And this is the figure which shows a model in which no B venom was not given. All rats died, while those given B venom, they recovered, they continued survival. About 50% of them survived. Okay. This slide shows the creatinine and PUN. Definitely the B venom protected from ischemic toxic injury, and also the histology in which degree of damage of tubular damage converted into number, it showed good protection of venom. Another example in which they used the experimental transplantation model in vivo, Treg expansion under co-stimulation blockade, STELLA 4, as immunosuppressive agents. They used the expansion of Treg to solve its problem. What is the problem with STELLA? STELLA 4 is a good drug for induction to prevent rejection, but many of cases the graft were lost. They believe that this is due to an effect on the Treg. It inhibits Treg. So in this model, they did cardiac transplant and no STELLA given. All rat died. They gave STELLA. Only some rat survived. But when they added Treg either late or early, the difference was little due to homing away from the graft. But when they give something to stimulate endogenous Treg, which we call interleukin-2 complex, they found 100% survival of cardiac transplant. Again, so we manipulating the endogenous Treg by this drug can protect the heart from rejection. There's another way in which STELLA 2, okay. I can reach to conclusion, okay. Okay, so, Mr. Chairman, dear colleague, I can reach to the conclusion, TERIG constitute a vital natural defense mechanism against inflammation and extension of acute renal insult. Manipulation of TERIG number up or down lead to resistance or increased susceptibility in kidney injury, respectively. All of our current knowledge is from mouse model, and human studies are needed to understand the role of TERIG in clinical acute kidney injury. Actually, there was a slide in which they used this TERIG in human model, in human trial. After bone marrow transplantation, we know there is graft versus host disease, which can cause mortality and morbidity. They give processed TERIG with the bone marrow transplant, and they reported less graft versus host disease. This was the first human clinical trial using TERIG, but in hematology, we hope to do it in nephrology. TERIGs themselves may be a novel therapeutic agent, or that they may be targeted pharmacologically to block renal injury and or promote recovery from acute kidney injury. And thank you.
Thank you very much, Professor Sobh, for a very brainstorming presentation. It may open the frontier for another way to avoid rejection and to manage transplantation.
Okay.
So it's open for one or two questions. So let me ask you, if you are going to increase TERIG, it will protect the graft, but what is the effect on infections?
This is a double weapon, double sword weapon. So it needs research in human, of course. This trial on bone marrow transplant was successful with no side effect, no problem. Of course, the same when you give a strong immune suppressive, when you give endoxan bunks, for example. What about infection? When you give rituximab, so you chose the time in which you give TERIG when you have a problem to solve a hot problem. So it is promising to help to treat intractable rejection, for example. Instead, you give so it is, instead of giving this potent immunosuppressive, we give this TERIG. Of course, it is a brainstorming, as you said. When to use, how to use, a lot of things we have to think in. But it deserves we as a nephrology community to try to understand and to use it in our research work, at least, especially using drug to manipulate it.
Question from the floor.
Thanks to our great science, Dr. Mohamed Sobh, for this lecture, which is coming, and immune therapy is coming about the three pillars of immune modulator for tolerance. One of them is T regulatory cell, and the other one will be autophagy inhibitors, and the later one will be the exhausted T cell inducers. About Treg, the available at time being that is used in transplants to be given in the early periods in order to reduce the immune suppressive at the end of the first year, in order to be maintained on single immune suppression. My knowledge about to be used in rejection, I want to comment from you, my dear scientists, for this. But available about Treg, processed Treg infusion is given in the early periods of transplant, and the patient is followed for about 48 weeks. At the end of the 48 weeks, about 60% of patients will be maintained in single immune suppression. Okay. What about to be used in rejection and your experience in this literature writing about usage of Treg in rejection?
Yeah. As I said to you, we need to understand the TERIG biology to do a lot of work in these areas. Yeah.
Well, thank you very much, Professor Sobh. And on behalf of the Egyptian Society of Nephrology, we'd like to give you